It's time for another warm-up review. Let's get going. Which drug category has each of the following endings? So first we have sartan, those are the angiotensin receptor blockers. Stigmine, those are going to be the cholinesterase inhibitors, things like neostigmine or physostigmine. Curium or curonium, those are going to be the non-depolarizing neuromuscular blocking drugs. Glitazones are going to be the TZD, so the thiazolidine diones. Dipene or dipene is going to be the dihydropyridine calcium channel blockers, things like nifedipine or amlodipine. Azepam or benzodiazepines. Conazole are going to be the antifungal drugs. Caine are going to be the local anesthetics. Cycline are the tetracycline antibiotics. And then Navir are going to be these protease inhibitors. All right, that brings us to the end of the warm-up. Let's get to that lecture.
Let's talk about heart murmurs. Heart murmurs are very high yield for step 1, easily a 5-star topic. You're likely to see at least a couple of questions where they give you some clinical information and ask you to listen to an audio recording and then identify the murmur. And we have some sample murmurs for you to listen to in a little bit, so make sure you're using headphones for this video, especially when we get to those heart sounds. Now, there are 3 key pieces of information you need to pay attention to on questions about heart murmurs. The clinical scenario, the location on the chest where the murmur is the loudest, and the timing of the murmur, whether it's systolic or diastolic. So, as we talk about different valvular lesions that cause murmurs, pay attention to those 3 pieces of information. Now, on the audio questions, they're going to show you an illustration of the patient's chest, and you can click on different areas of the chest and hear how the murmur sounds at different locations. And there's a separate window with a computer-animated patient, and you can see the chest rising and falling as the patient breathes. So you can listen for whether the murmur changes during inspiration or if there's paradoxical splitting of S2 or wide splitting or whatever. But the most important things to focus on are the clinical scenario, the location of the murmur, and the timing of the murmur. So what do we mean by the location of the murmur on the chest? Well, placing your stethoscope on different areas of the chest allows you to listen to different valves. There are tons of different mnemonics for these, like Apartment M, or All Physicians Take Money, or All Patients Try Medication. But whichever mnemonic you use, A is the aortic valve, which is heard best at the right second interspace, adjacent to the sternum. P is for the pulmonic valve, which is heard at the left second interspace, adjacent to the sternum. T is for the tricuspid valve, which is heard at the left fourth interspace, adjacent to the sternum. And then M is for the mitral valve, which is heard at the left fifth interspace in the midclavicular line, out at the apex of the heart. So you have to know what valve you're listening to when you put your stethoscope on the chest. And before we get into the murmurs themselves, there's a question in the study guide that says what abnormal heart sounds are considered benign when there's no evidence of disease. Now, if there's evidence of disease like syncope or poor perfusion or any other evidence of cardiovascular disease, that's a different story. But if there's no evidence of disease and you just happen to hear one of these incidentally, it's not a big deal. They are a split S1, a split S2 on inspiration, an S3 heart sound in a patient younger than 40. So if you hear an S3 in a patient older than 40, you need to think about heart failure, maybe from ischemic cardiomyopathy. But an S3 heart sound in a patient under 40 is generally benign unless there's evidence of disease. And then the fourth one is an early, quiet systolic murmur. So if it's a holosystolic murmur or a loud murmur, or if there's evidence of disease, it's not benign. But an early, quiet systolic murmur in a patient with no evidence of disease is generally not a problem. Most of the murmurs we're going to talk about are related to valvular heart disease, because if the valve doesn't open completely or doesn't close completely, that's going to cause turbulent flow of blood across the valve, and that's what makes the murmur sound, turbulent flow. So it can be very helpful to think about when blood is flowing across each valve in relationship to the cardiac cycle, because that's going to help you really understand why certain valve lesions cause systolic murmurs and why other valve lesions cause diastolic murmurs. So what's going on in the heart during diastole? Well, the ventricles are relaxing, they're filling with blood. So which valves are going to be open during diastole? It's the mitral valve and the tricuspid valve. So if you know that, you can reason out what types of valve lesions will cause diastolic murmurs. Stenosis of the mitral valve or stenosis of the tricuspid valve will produce a murmur during diastole. The blood that's flowing from the atria to the ventricles can't pass through those stenotic narrowed valves very easily, and that generates turbulent flow and that generates a murmur. So those are examples of diastolic murmurs, mitral and tricuspid stenosis. And then what are the aortic valve and the pulmonic valves doing during diastole? Well, they should be closed. Normally there's no blood flowing across the aortic valve or the pulmonic valve during diastole. But if the valves don't close completely so that some of the blood can leak back into the ventricles, that's going to cause a murmur. We call that leaking of blood regurgitation. So aortic regurgitation and pulmonic regurgitation will also cause diastolic murmurs. Now you have to be able to listen to a murmur and tell if it's systolic or diastolic. When you hear a diastolic murmur, it's generally going to be one of those four I just mentioned: mitral stenosis, tricuspid stenosis, aortic regurg, or pulmonic regurg. And then if you hear the diastolic murmur best in the mitral position, you know it's mitral stenosis. Or if you hear that diastolic murmur best at the pulmonic position, you know that's pulmonic regurgitation. Now, what about systolic murmurs? Well, think about what happens during systole. The ventricles are contracting. So, which valves do you expect to be open during ventricular contraction? Well, the aortic valve and the pulmonic valve. So, stenosis of either the aortic valve or the pulmonic valve is going to cause a systolic murmur. And then regurgitation through the mitral valve or the tricuspid valve can also cause a systolic murmur. So make sure you can reason that out. Understanding physiology is much better than simply memorizing it. There are some bedside maneuvers that you can have the patient perform that's going to change a heart murmur. Either make the murmur louder or softer, or make it longer or shorter. Now, this can get very confusing, so I want to keep it simple. And again, I want you to try to understand what's going on so that you can reason it out instead of just memorizing it. First of all, think about how breathing affects the pressures in the heart. During inspiration, there's negative intrathoracic pressure. That negative intrathoracic pressure pulls blood from the vena cava into the right atrium. So during inspiration, you have more right atrial filling. So which type of murmur do you think is going to be louder with more blood filling the right atrium during inspiration? A tricuspid murmur or a mitral murmur? Well, tricuspid murmurs on the right side of the heart become louder during inspiration because there's increased blood flow across the tricuspid valve. But with the mitral valve, the opposite is true. Mitral murmurs become louder with expiration because you're filling up the left atrium more. A couple of students have suggested that the I in right could remind you that right-sided murmurs are louder during inspiration, I for inspiration. And then the E in left can remind you that left-sided heart murmurs are louder during expiration. Another maneuver is hand grip. You tell the patient to make a tight fist and hold it for 60 seconds. And when those muscles are contracted, they clamp down around all the arteries in the forearm. And that increased tension is going to increase systemic vascular resistance and increase afterload, and that makes the murmur of mitral regurgitation louder, as we're going to see. There's also the Valsalva maneuver, where you have the patient close his mouth or close the glottis and bear down like they're straining to go to the bathroom. The Valsalva maneuver will increase intrathoracic pressure, so it's kind of the opposite of inspiration. It reduces venous return to the right side of the heart, and it also reduces systemic blood pressure if you have them Valsalva long enough. So Valsalva reduces both preload and afterload, and it makes most heart murmurs quieter. But there's one murmur that gets louder with Valsalva. That's the murmur of hypertrophic cardiomyopathy. Now, we're going to talk about hypertrophic cardiomyopathy another time in the video on cardiomyopathies. But I want you to file that away from now. Valsalva makes most murmurs quieter, but it makes the murmur of hypertrophic cardiomyopathy louder. So let's look at some specific murmurs and the conditions that cause them. We're going to review the diastolic murmurs first, starting with aortic regurgitation. Now, this is a phonocardiogram of an aortic regurgitation murmur. It's a visual representation of what the murmur sounds like. So you can see the S1 heart sound, which occurs when the mitral and tricuspid valves close. And you also have the S2 heart sound when the aortic and pulmonic valves close. So on this phonocardiogram, you can see that aortic regurgitation is causing a murmur during diastole, after S2. And I want you to take note that the murmur begins immediately after S2. Again, think about what's going on during diastole. The aortic valve should be closed, but in aortic regurgitation, as soon as the ventricles start to relax and the ventricular pressure starts to drop, blood starts flowing backwards from the aorta into the left ventricle. You're going to start hearing that diastolic murmur immediately. Aortic regurgitation is usually heard the loudest along the left side of the sternum because that regurgitant jet of blood is kind of shooting right down into the left ventricle. Another clinical clue to the diagnosis of aortic regurg is a wide pulse pressure. Instead of a blood pressure of 120 over 80, it might be 120 over 40. Think about it. The left ventricle has ejected a bunch of blood into the aorta, and then as the heart relaxes, some of that blood is starting to flow back into the left ventricle, regurgitating back through that leaky aortic valve. So the systolic blood pressure is normal, but what happens to the diastolic blood pressure? Well, as that blood flows back into the ventricle, the pressure in the aorta drops off rapidly. So the systemic diastolic pressure will tend to be low, and you have a wide pulse pressure. And then a couple of exam findings they might give you without actually giving you the blood pressure readings are that this wide pulse pressure can make the peripheral pulses feel really strong and bounding, which is sometimes called a water hammer pulse. And sometimes you see a subtle head bobbing because of that strong arterial pulse. You feeling okay, Dr. Lewis? Now, what kinds of things cause aortic regurgitation? Well, it can be due to dilation of the aortic root. So why would the root of the aorta be dilated? Well, one reason is syphilis. We don't see syphilis very often in the U.S. anymore, but tertiary syphilis can cause dilation of the thoracic aorta and some aortic regurgitation. And it can also sometimes cause aortic stenosis. Another cause of dilation of the aortic root is Marfan syndrome, which can result in aortic regurgitation. Then another cause of aortic regurg is a bicuspid aortic valve. So instead of having a normal 3-leaflet aortic valve, the patient just has a 2-leaflet valve. Now that most commonly causes aortic stenosis, as we're going to talk about later, but it can also cause some aortic regurg. Then a final cause of aortic regurg would be rheumatic fever. Rheumatic fever can cause all sorts of valve lesions. Let's talk about mitral valve stenosis. One thing you'll notice about mitral stenosis is that there's a little pause between S2 and the beginning of the murmur. Now, that's different from aortic regurgitation, where the murmur started immediately after S2. So why is mitral stenosis different? Well, S2 occurs when the aortic valve and the pulmonic valve close. At that moment, all 4 valves are supposed to be closed. The ventricles are relaxing and the pressure in the ventricles is dropping, but the pressure hasn't dropped enough for the mitral valve to open. So with all 4 valves closed, the volume in the ventricle isn't changing. So this is the isovolumetric relaxation period. But the important thing is that the valves are closed, including the mitral valve. And if there's no blood flowing across the mitral valve, there's no murmur. So in mitral stenosis, the murmur starts a little bit after S2 because the mitral valve hasn't opened yet. Then when it does open, it's stenotic or narrowed, and there's a snap when it opens. You can think of it as though the leaflets are sort of stuck together, and in order to open, it has to snap open. Even if you don't quite notice that subtle distinction, the other key feature that's going to help you tell mitral stenosis from aortic regurg is the location. We said that aortic regurg is heard along the left border of the sternum, but mitral stenosis is heard loudest at the mitral position, at the apex of the heart, the 5th intercostal space in the mid-clavicular line. Mitral murmurs are also heard best when the patient's lying in the left lateral decubitus position. So you have the patient roll over onto his or her left side, you put the stethoscope on the mitral area, and that murmur may be easier to hear. Now, what other heart sounds are heard best in the left lateral decubitus position? Well, there's mitral stenosis and also mitral regurgitation, and a left-sided S3 heart sound or a left-sided S4 heart sound are also going to be heard best in the left lateral decubitus position. The murmur of mitral stenosis is enhanced by expiration and other maneuvers that increase blood return to the left atrium. So again, we see that expiration is going to enhance left-sided murmurs, like mitral murmurs. Then one other thing to highlight is the S2 heart sound. Sometimes it's tricky to tell whether you're listening to a split S2 heart sound or a normal S2 heart sound with an opening snap due to mitral stenosis. Well, the opening snap of mitral stenosis is going to be followed by the murmur, obviously. But another clue is that the splitting of S2 is exacerbated by inspiration. So inspiration makes S2 more split, while the opening snap and the murmur of mitral stenosis are enhanced by expiration. So that could help you. Mitral stenosis is often caused by rheumatic heart disease, which can lead to scarring of the mitral leaflets. And then chronic mitral stenosis can result in left atrial dilation, which makes sense if you think about it. If you're not able to empty the left atrium because that mitral valve is stenotic, there's going to be more blood and more pressure in the left atrium, and over time, the left atrium will dilate. Let's touch on the murmur you hear with a patent ductus arteriosus, or PDA, which is a non-valvular lesion. These other murmurs so far have been caused by valve problems, but a PDA is a non-valvular murmur. This is a continuous machine-like murmur that's heard throughout both systole and diastole. It kind of sounds like whew, 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 whew. It's continuous. There's always blood flowing through the PDA. Now, how do we keep a PDA open? With prostaglandins. And how do we close it? With NSAIDs like indomethacin. So that's pretty much it for the diastolic murmurs. We're going to cover systolic murmurs in the next video. So for right now, let's take a look at the end of session quiz. First question, through which heart valve should blood be flowing during systole and during diastole? So during systole, blood should be flowing through the aortic and pulmonic valves, and during diastole, it's the tricuspid valve and the mitral valve. Next, what are the diastolic murmurs? Well, there's tricuspid stenosis, mitral stenosis, aortic regurgitation, and pulmonic regurgitation. And the last one, what murmurs are heard best in the left lateral decubitus position? Well, we said it was your mitral murmurs, both mitral stenosis and mitral regurg, and then also left-sided S3 and S4 heart sounds. Then we have 2 rapid-fire facts for this video. Bounding pulses, head bobbing, and a diastolic murmur, that should make you think about aortic regurgitation, and a continuous machine-like murmur should make you think about PDA. That's it for now. I'll see you next time. Come on, Dr. Lewis. Let's go get your echo.